Thank you very much. And I'd like to thank the organizers for this invitation to share with you our work on the development and early clinical implementation of a non-invasive prenatal multi-gene sequencing screen. And I'm going to use that title for this assay throughout the presentation, but the assay is also known by two other names, just so there's no confusion. One is PreSeq, and the other is Vistara. They're actually the same test. Vistara is marketed by Natera, but our lab at Baylor performs both of the tests and interprets them. This is my first time having the pleasure to attend this meeting, and so I will give a disclosure and also an introduction to you. I'm a full-time faculty member of the Department of Molecular and Human Genetics at Baylor College of Medicine. You heard some of our work reviewed briefly in the morning session, so I'm part of the Baylor group that has worked on fetal exome sequencing as well as universal carrier screening. Through a professional services agreement, I serve as Chief Medical Officer and Chief Quality Officer of Baylor Genetics. This is a joint venture genetic testing laboratory between a large Japanese laboratory company called Morocco Holdings and Baylor College of Medicine. I also receive grant funding from the National Institutes of Health, but it's mostly for postnatal genomic testing projects. So I'd like to give you a brief summary of what I'm going to be talking about over the next 30 minutes. I'm going to be discussing the development and early experience of a non-invasive multi-gene prenatal screen for a panel of 30 genes in which we report pathogenic and likely pathogenic variants. We feel that it works as a complementary screen to traditional NIPT that we've been hearing about during this session, and that it allows a more complete picture of the risk of the pregnancy being affected by a variety of different kinds of genetic problems. It detects predominantly de novo variants in 30 different genes, and it allows for the detection of variants that cause clinically significant genetic disorders such as Noonan spectrum disorder, Cornelia de Lange syndrome, and osteogenesis imperfecta. And then per ACMG and ACOG guidelines, the risk of having a child with single gene disorders such as achondroplasia and Cruzan syndrome, among others, increases with advanced paternal age. So this assay is now one of there's actually one or two others available now, prenatal screen to detect disorders with an increased prevalence that may be linked to advanced paternal age. So this slide, or this concept, has been presented several times today and also yesterday, but population-based screening for genetic diseases by molecular testing is available in a number of different settings. First, there's carrier screening, and this can be either smaller panels or larger, what's called universal carrier testing. And of course, this screens for autosomal recessive or X-linked diseases such as Tay-Sachs, CF, Fragile X, and Duchenne muscular dystrophy. And when these are full sequence based, they become pan-ethnic tests and not targeted to a specific ethnic group. There's also, as we've heard during this meeting, non-invasive prenatal screening. This is mainly for chromosomal abnormalities and microdeletions or microduplications. But there's another class of disorders, namely dominant diseases caused by de novo mutations, for which there's not currently a screening protocol that is available. So part of the rationale for the development of this screen was that, and this we've heard also in the course of this meeting, is that patients are having a negative perception of diagnostic procedures. The negative perception that patients may have about invasive testing can conflict with their desire for information about the genetic status of their pregnancy. And we've seen a statistically significant decline in the number of invasive procedures in this past decade, particularly because of the advent and the success of NIPT. In one population study, invasive testing decreased significantly by almost 40% from 2012 to 2015 despite a steady number of births in a particular state in the United States. So one of the challenges then for our field is to improve and expand upon non-invasive screening options. So what are the risks to a pregnancy, and how good are we at detecting them? I think we've also heard several times that chromosomal aneuploidy explains about, and it depends on the study that you're quoting, about 8 to 30% if there are sonographically detected fetal anomalies. There was a few years ago an NICHD prenatal CMA study and also several other meta-analyses that showed that an abnormal karyotype would be found in 8 to 10% of all of these samples. An additional 1 or 2% with a normal karyotype will have an abnormal CMA, and then an additional 6% will be positive if there are sonographically detected fetal anomalies. But again, there are up to 60 to 70% of patients with sonographically detected fetal anomalies who do not have a genetic diagnosis after this, the testing that is more commonly available. And I'd like to thank my colleague Inja Vandenbever for this slide. Of course, we know that current screening is highly focused on aneuploidy, and here are some figures from a paper from 2007 by Carlson that shows the aneuploidy and the frequency, and also the age-related risks. So we can see for trisomy 21, the frequency is about 1 in 800 live births. If we look at age-related frequencies, of course, it increases with increasing maternal age. Up to, let's say if we take a look at age 35, it's about 1 in 353 risk for trisomy 21, and about 1 in 178 for other chromosome abnormalities. If you contrast this with this study that looks at the incidence or the prevalence of genetic disease in more than 1 million consecutive live births, and this is from a paper from 1988. If you look at dominant, recessive, and X-linked, you'll see that there is a cumulative percentage of total births of about 0.36%, or 1 in 278. So again, this emphasizes that single gene disorders do play a prominent role in genetic disease. I'd like to also highlight some of our experience from clinical whole exome sequencing performed in our lab at Baylor in over 10,000, this is postnatal samples, and having a look more closely at whether they're autosomal dominant, autosomal recessive, or X-linked. So whole exome sequencing in a postnatal setting has a diagnostic rate of about 30%. And this has been shown in many, many different studies from many different labs. It differs a little bit if it's proband only versus trio, but it's typically somewhere between 25 to 35%, depending on the studies. We see here that the majority of autosomal dominant variants found in a postnatal setting are actually de novo. So of the total, and I'm looking for the pointer. So these are the diagnosed cases. So about 53% are autosomal dominant, 36% are recessive, and about 13% are X-linked. And of the autosomal dominant, about 74% are de novo. 11% are unknown. 11% are inherited, and 14% are unknown. And that unknown is because we didn't have both parents to test. So at least 74% of the autosomal dominant conditions that we diagnose by postnatal exome sequencing are the result of de novo variants. We know that de novo variants have a higher incidence within a setting of advanced paternal age, and this is from ACOG and ACMG, and they acknowledge, this is fairly from 2008, and then again in a practice bulletin from 2016, there is an increased risk of having a child with a single gene disorder because of an increased rate of de novo mutations in sperm. And examples of these disorders are achondroplasia, Crouzon syndrome, and Apert syndrome. There's no strict definition for what constitutes advanced paternal age, but it's thought to be between 40 and 45 years of age, but definitely more investigation needs to be done about defining what the exact age is. Currently, there's no recommended screening or diagnostic panels that target the disorders that may be increased with advanced paternal age, and pregnancies are managed with standard screening and diagnosis. And these are the disorders typically that are seen, that may be seen with advanced paternal age, and the relative risk as well as the population risk. And this is from a paper from 2008. We also know that cell-free DNA diagnostic testing is available for known and suspected single gene disorders from high-risk pregnancies. And this is, of course, the work of Lynn Chitty and her publication along with Dr. Haywood from 2018. And these disorders, such as achondroplasia, thanatophoric dysplasia, Apert Crouzon, are included in these as diagnostic tests. So there is currently not a screening test available for this class of disorders. And so we went about trying to design a panel for which genes would be part of this multi-gene screening panel. And so the characteristics of these disorders or these genes are that they would have a higher incidence of de novo occurrence, particularly with advanced paternal age, such as FGFR2 and FGFR3. There should also be a clinical impact for the selection of these disorders, either the need for prenatal or perinatal care and management, such as with a skeletal dysplasia, or early surgical medical intervention, or perhaps cognitive disabilities, such as with MECP2. This may be difficult to see, but these are the genes that are included in the non-invasive multi-gene panel that we designed. It's comprehensive for Noonan spectrum disorders. For skeletal disorders, there's FGFR3 and COL1A1 and COL1A2. And there are also syndromic disorders such as Alagille syndrome, Charge syndrome, and then the craniosynostosis syndromes that are FGFR2 related. In terms of the clinical criteria for testing, we are testing singleton pregnancies greater than 9 weeks of gestational age. There can also be fetuses with abnormal ultrasound findings consistent with a disorder in our panel. We also will accept cases where the father has a definitive diagnosis of a disorder included in the panel, and there may be other indications as well. And we know that clinicians, once they know about the availability of a test, will often find other indications where this test may fit. At this point, we do not accept twin pregnancies, and we do not accept a case where a mother has the definitive diagnosis of a disorder included in our panel, such as Noonan syndrome. This is the workflow. At this time, we are currently doing trio analysis. So this is genomic DNA from both the mother and the father, biological samples, biological parents, as well as plasma from maternal blood for the cell-free DNA. We do the NGS capture-based procedure on all three samples, and we analyze the data simultaneously to look for de novo variants, and then we report out those that are pathogenic or likely pathogenic. We use molecular barcoding as a way to reduce NGS error. So as we all know, errors can be introduced during PCR and sequencing, and this may interfere with the detection of low heterozygous calls. So we uniquely tag the DNA fragments very early in the process, and by ligating these adapters to the fragmented DNA. When we do the analysis, the higher the number of unique barcodes that are associated with a particular variant that we're interested in, the more reliable the result. This is a summary of the test performance. We looked at true negatives and true positives, and the analytical predictive value was calculated to be over 99% for both positive and negative predictive value. I'll give you some data on the validation and the early clinical experience with this test. This is from the first 438 samples that were received. 35 were excluded from this analysis because they didn't meet one of several criteria. We may not have received enough blood, it was collected in the wrong tube. There were some ovum donor issues that we couldn't clarify well. 2 had twin pregnancies, and 18 did not meet the fetal fraction cutoff of 4.5%. So 403 were included in this analysis. Of those, 372 had negative results, but of those, several had abnormal ultrasound findings. There were 117 with those, 24 with previously affected child or pregnancy, and other factors. 31 were positive, and of those, 27 had abnormal ultrasound findings, and 4 had a positive paternal history. This is a closer look at the indications for sending the test. 24% had a previous child or pregnancy affected, and 55% had an abnormal ultrasound finding that was skeletal. And you can, those are numbers. So 13% had abnormal ultrasound findings, which were skeletal in nature. 5.7% had increased abnormal ultrasound findings or increased NT, and I think you can see the other figures there. The area with the most positive cases was from the abnormal ultrasound findings that were skeletal in nature, and that was 19 out of 55 cases were positive. This is a look at the genes that were identified, and these in the 31 positive cases. And again, we report only pathogenic and likely pathogenic variants. So FGFR3 had the highest number of positive cases with 10, and that is of course associated with anatophoric dysplasia or achondroplasia, followed by COL1A1 and COL1A2. Interestingly, when we took a look at the paternal age for these cases, and again, these are all de novo findings, 27 are caused by de novo mutations with an average paternal age of 35. So when we were discussing what is the appropriate definition of advanced paternal age, we may need to start to reconsider that as we have more data. We performed a follow-up study to try to get outcome data on these cases. So we contacted 498 cases, and that was the number when we started this follow-up study, the number of cases that we had. Of those 498 cases, we received responses from 233, and this contact was typically by phone. And of those, we had positive cases responding, of 35 of those cases, and 198 negative cases responded. We had positive confirmation for 20 out of the 35 cases. The rest we either we didn't have definitive confirmation because the family either declined diagnostic testing or it was unknown what the outcome of the pregnancy was. And for the negative cases, they were confirmed negative by the follow-up, except the status of 71 of those remained unknown because the provider did not have follow-up information. So the follow-up survey, we had responses from 46.7% of the total cohort, which confirmed 20 of the positive results, and 127 negative results, with no false positives or negatives reported thus far. Just like to, in the next few minutes, go over some of the clinical cases to give you an idea of some examples of the cases that have utilized this testing. The first case had a gestational age of 18 weeks and 4 days. The abnormal ultrasound findings consisted of hydrops, a VSD, cystic hygroma, low and small low-set ears, and a pleural effusion. There had been negative prior aneuploidy, NIPT, as well as karyotype CMA and a Noonan panel by NGS. So the results of this test was that the fetal fraction for this case was 9%, and we identified a known pathogenic variant in the RIT1 gene. This was previously identified, there were this was a de novo occurrence that was seen in other Noonan spectrum disorder patients and not observed in various databases. Functional studies of this variant suggested a gain of function, which is consistent with the pathophysiology of Noonan syndrome, the molecular pathophysiology. And this variant was not detected in parental samples. Confirmation testing was performed on this pregnancy through targeted testing in the RIT1 gene from extracted DNA that was saved from this amniocentesis. And the reason this was not detected in the NGS Noonan panel was that the RIT1 gene was not included in that particular panel. A second case, this had a gestational age of 35 weeks. There was an abnormal ultrasound with micromelia, skeletal dysplasia, mild dolichocephaly, a small VSD, and persistent right umbilical vein. Prenatal microarray and chromosome analyses revealed a 47XXY karyotype, which was not felt to be consistent with the ultrasound findings. Fetal fraction here was 18%, and we detected by this screen a known pathogenic variant in the COL1A1 gene. This is reported multiple times in the literature, and this variant was not detected in the parental samples. And this family underwent invasive study, and the variant was confirmed by that testing. A third case had a normal fetal ultrasound at 20 weeks, 5 days gestation. And in this case, the father had a known clinical diagnosis of OI type 1, a mild form, but he did have a history of neonatal fracture. The fetal fraction for this case was 10%, and we identified the pathogenic variant, which was known to be in the father's, known to be positive in the father as well. This variant has been reported in multiple patients with OI type 1, and the same variant, of course, was found in the paternal genomic DNA, which we test at the same time. So this is a case where the family wanted the information but did not want to undergo invasive testing. We've had other results where the same indication was applied for testing and where there was a positive paternal history, but we've had several cases that have been negative through our NIPT screen. It's still relatively early to calculate the clinical PPV. A follow-up study, I think, gives us very useful information in that we have not identified a false positive or false negative result yet. But I do want to emphasize that we do recommend confirmatory testing and clinical correlation for these results in that they are a screening test. So in summary, we have developed a novel test for non-invasive screening of 30 genes that are associated with autosomal dominant and autosomal, and X-linked genetic disorders. Our early experience demonstrates a positive rate of about close to 8%, but this is a relatively high-risk cohort because we have seen a relatively high number of cases with ultrasound abnormalities, and we do have a number of cases from fathers of advanced paternal age. Early clinical experience with this test has demonstrated utility in patients with prenatal ultrasound abnormalities, for fathers affected with one of the disorders, or for couples desiring additional prenatal options. And I'd like to acknowledge my colleagues at Baylor College of Medicine, particularly Jinglan Zhang, who is the leader of this study, and also other colleagues at Baylor, particularly Inya Vanden Wever. I'd also like to acknowledge some colleagues from other universities, Columbia, University of Kansas, and CUHK in Hong Kong, and particularly some colleagues at Natera, the genetic counselors, Jennifer, as well as Shital, led a group that helped with the follow-up study by telephone. Thank you very much.